session called Master MDS for Enhanced Patient Care. My name is Guillermo Garcia-Manero from MD Anderson, and I'm super happy and honored to be here with Dr. Maria Diez-Campello. So Dr. Campello is the leader of the Spanish MDS group that I think is like probably the most active group right now in the world, representing a country, and really a great colleague and thought leader. And also with Dr. Sangeeta Benagopal from the University of Miami, that is also an expert on MDS and related conditions. It's really an honor to be here with both of you. So this is just a little token, like if you look at this QR, I guess we can win, maybe I don't have my phone, I'll try to do it, it's a joke anyways. So try to click here. And then if you go to that website called peerview.com, 2025 MDS, I think you can get a lot of the information and the slides from these presentations. Okay, so we have a few polling questions, and I believe this is the first one. I'm not going to read the 8 of them, just the title. So reflect on your practice. Choose an option that you think represents an ongoing challenge in treating patients with lower or higher risk MDS. So I'll give you a little bit of time to go through this. I guess you have to scan on that QR. Okay, and we have the answers. Ready for the next? I think what this slide shows is kind of relevant because we're talking about how to interpret the data from the COMMANDS trial that has been so important, how we sequence therapies, and I think these are questions that are going to come through the presentation. I maybe just move to the next slide. Yes, okay. And then this field is kind of an evolution, and indeed, actually, I believe that there is a meeting in the next few months, early in 2026, where both the WHO and the ICC groups are trying to get together to see if we can develop a new classification for this disease. Like, you know, we don't have anything else to do. But the bottom line is, as you know, there's been kind of a transition over the years in terms of how we call this disease, you know, what type of parameters we use to classify it. I think when I look at WHO versus ICC, the main thing is this kind of cutoff of more or less than 10% blast, and I'm quite open saying that I don't believe that AML should be considered more than 10% blast. These diseases are totally different, they have totally different behavior, and therefore they likely need a different approach. What has really been a game changer is this issue of incorporating molecular data in our understanding of these patients, and by that I mean, you know, around 10, 15 years ago, we started using NGS data, and then finally, a couple of years ago, we got this IPSS molecular that we all use, and this actually has really transformed our view of these patients, how we prognosticate them, and hopefully in the future also how we conduct clinical trials. Now, I think that, I don't know if this happens in other diseases, but in MDS, this is actually quite important. We have this kind of separation, this dichotomy between what's happening in terms of clinical trials, what we would like to do for our patients, and maybe what happens in the real world. These patients are older, they may have comorbidities that incidentally we think more and more are part of the disease. But the reality is that when people do this kind of real world data or looking at electronic health records, we see actually that only a fraction of these patients are treated. And this is actually heartbreaking to me because we put quite a bit of energy in developing these compounds that we think in the right context can be quite effective, yet this may not always translate, at least in the United States, to the full population of those patients. So for instance, you see here that in first line of almost 1,500 patients, only a third of them went on to receive second line therapy. And this is kind of an issue because we now have second and third line and even targeted approaches for our patients. And then the other very interesting thing is that, and this probably relates a lot to these ESAs that we have used for so many years, is that we have these drugs, we use them, they actually don't really work in a significant fraction of patients, but they've been with us for a long time. But then somehow we have some inertia where we don't really move to the next step. So that's actually fascinating, particularly as you will see through the next 3 talks, that the therapeutic armamentarium for these patients is really evolving. So we really need to be a little bit more assertive when it comes to our treatment options for these patients. So this is like a slight short introduction. So what are the goals for today's presentation? So hopefully we'll be able to convey kind of a modern understanding of MDS. We're going to be talking about frontline, first-line therapy for patients with low-risk MDS and anemia. We're going to be talking also about new clinical trials in high-risk MDS, and hopefully like a holistic approach of how we, the 3 of us, see the treatment of this disease. Before we move into the actual talk, we want to acknowledge Health3 Cure Hub. It's actually an innovation that powers life-saving research, and it's actually supporting quite a bit of what we're going to be presenting today. And with that, we're going to start with the first talk, and we're going to be discussing in my part low-risk MDS, and we like to use a clinical vignette to basically have a conversation around what we're going to be discussing. So this is a gentleman that presents with low-risk MDS and some comorbidities, so 78, some renal dysfunction, some coronary artery disease. Let me start here by saying that in the past, we thought that these were kind of things that happen as part of aging, meaning, you know, you're older, you have coronary disease, you have MDS, but we're starting to understand that some of these comorbidities may be actually somehow related to this myeloid clone. So it's possible that the coronary disease that this individual has may be somehow also related to his MDS. He has some cytopenia, has anemia, you perform a bone marrow exam. Of course, that's perhaps the very first step that doesn't happen universally. Sometimes these older individuals are not evaluated to the extent that they should. And in that bone marrow exam, you see erythroid dysplasia. You see these cells that we call ring sideroblasts, occupying 25% of that particular compartment. This in itself actually is fascinating because for us, this is trivial. This just requires an iron stain, but in some countries, actually, there is no even expertise in doing this kind of test. And the patient has a low percentage of blast. Your chromosome, that is still a key part of how we evaluate these patients, is normal, and this patient with low-risk disease is quite crucial to exclude that the patient has a del5q alteration because the treatment of that is quite specific. And then you run your next generation sequencing assay that most of us now have in our clinics. And what you see is that this patient has the most frequent mutation in low-risk MDS. That is this SF3B1, very important splicing factor. Now what you see is that next to it, it says K700E. So this is the most common codon mutated in this disease, and is particularly associated with a more benign prognosis. This is like the true phenotype of low-risk ring sideroblastic anemia with a significant VIF. I say that because not all SF3B1 mutations are as benign. Some of them actually are seen in the context of more aggressive disease. And then very important, this patient does not have a TP53 mutation. This actually will be kind of not that frequent in this group of patients with low-risk disease, but it's very important to evaluate. No targetable mutations such as IDH1 or 2. Patient is some aspirin because of the coronary disease, and is transfused 2 units of red cells every 3 weeks for 4 months. So this patient is clearly transfusion dependent, is fatigued. This is an issue that we have been discussing actually with Dr. Diaz-Campello yesterday in a couple of meetings in terms of how we assess symptom burden, you know, what is the impact of those, can this be actually some type of tool that we could assess in clinical trials. And then for fun, this patient actually has a serum EPO level that is kind of the limit of what will be threshold of an EPO where ESAs may or may not work very effectively, and is clearly anemic. So the question here now is, in 2025, at the end of this year, what are the goals of therapy? And how important actually is this transfusion burden. And this to me is something that is changing dramatically, and I hope that I can convey that over the next few minutes, because we've gone from a situation where we just wanted to stabilize hemoglobin levels, then we wanted to decrease transfusions, and now, as you will see soon, we're starting to ask the question, is it possible that we're changing the natural history of this disease? In other words, are these patients living longer because of this intervention? So here then, the question is, what will be the first-line option for these patients? And is there a role, for instance, for luspatercept in this group of patients based on this COMMANDS data that we're going to be discussing next? Now, what is really clear is that this RS-positive patient with SF31 K700E is like a really clear case where that data will apply. The question that we will also be trying to address through the next few slides is, what will be our approach if the patient was RS negative, meaning no ring sideroblasts, no SF, the same type of approach for him or not. So first start with some slides that I have to disclaim I never understood, and now they're starting to make sense to me. That is the impact of anemia and transfusion dependency in the disease itself. So as you see, these slides are like the original one, 2007. Some of these papers are around this time. And I couldn't understand them because in my mind, it was all associated to the risk of the disease. So if you had more or less worse disease, then you're... But here, what these investigators were showing is that this had independent value. And I could not kind of dissociate one from the other. But this is actually becoming very clear, that there is something about this need of transfusions and the transfusion burden as a really independent prognostic variable in patients with this disease. So this is now becoming an issue because improving these transfusions not only is fundamental for the well-being of our patients in terms of quality of life and other issues, actually it may be what results in improving their survival. So I think this is actually still, so many years later, a very important concept that now maybe finally I'm starting to understand. The other issue, and this is data from Dr. Diaz-Campello, is the burden of this process. And I work in a very large hospital in Houston, and I can tell you this is with the largest blood bank in the world for a single center. This is a huge deal for us. You know, patients spend there like all day. You have to type and cross these patients. And then you think these things are these transfusions are benign and not costly, but they have significant cost, and they're associated with significant toxicity. So if you work in a big center like mine, eventually you get called weekly for this patient who is heavily transfusion dependent, that now has TACO and needs to go to the ICU because of some complication, etc. So there's a significant cost for these individuals that tend to be elderly, having to come, one time a week or sometimes more than that for this type of care. And as you see in this slide from Maria, that I think is actually quite important, it's not only an individual issue for the patient itself, for the patient, right? These are individuals that are older, so they depend in the family, etc. So there is a significant burden to these patients. And I think the field is moving into more effective therapies for anemia. We're actually also moving into these oral hypomethylating agents that hopefully will also help a little bit in this particular issue of your dependency to the center, which is something quite important. There's been a little bit of in my opinion, controversy in terms of these NCCN guidelines. And I was listening that maybe there's some European and international guidelines. But I used to serve on this committee until a few weeks ago. And the bottom line is, what you will see when you go to the NCCN guidelines is you have this group of patients with RS-positive disease, with this SF31 mutation. By the way, not only the K700E, I was just mentioning that mutation is associated with a particular good prognosis, where the indication based on the COMMANDS data, and we're talking about first-line therapy, is obviously luspatercept. And then you will see that there is an option for Imetelstat, a telomerase inhibitor that actually Dr. Diaz-Campello helped very much develop, for patients with an EPO level more than 500. And I emphasize this because on the COMMANDS trial, we excluded patients with EPO level more than 500 because we were comparing luspatercept with an ESA. So there may be a small group of patients where you could consider the telomerase inhibitor upfront if their EPO level is elevated over 500. Then you have the group of patients with RS negative disease. And here, the guidelines are not that clear. Remember, actually, that it is quite infrequent to have a high EPO level, meaning high over 500 at initial presentation. That's actually uncommon. It can happen. And there, if your EPO level is less than 500, you have an option of using luspatercept or using an ESA. And here, you will go through the data and you will make your proper decision. Now, if your EPO level is more than 500, this gets a little bit complicated. These guidelines talk about ISTs, meaning kind of aplastic anemia-based therapies. I have never done that, actually. I don't know if Dr. Diaz-Campello or Dr. Venugopal do that in their practices. So, sometimes these guidelines have these experts, but I'm not sure actually how they come with these conclusions. For us here, the role will be maybe, Imetelstat based on against the Imetelstat study. There is significant use of hypomethylating agents in low-risk disease in North America. And there may be other opportunities for these patients. I think what you remember here is RS positive versus RS negative. And then over the last few years, we've been working on developing these drugs that inhibit TGF-beta pathway that actually, through some kind of experiments that were related to some other pathway, actually looking at bone metabolism, indicated that if you block TGF-beta, you may actually increase what they call late-stage erythropoiesis. It's actually a very interesting concept. So the idea here is that there's not like a direct inhibitor of this pathway. What you do is bind the ligands that activate the pathway. So if you trap them, and that's what the luspatercept is, it's an antibody that will go and trap those ligands, then you have less signaling through this pathway. And this actually eventually results in enhancement of late erythropoiesis. Why understanding the mechanism of action is important is because it will give us, at some point, some ideas in terms of how we combine different drugs that may work in different stages of erythropoiesis. Now, the COMMANDS trial was a very large international study. Dr. Diaz-Campello and myself were part of this study, so it happened basically all over the world. In my opinion, extremely well designed, and I say that because there were a lot of pre-planned analyses that now are giving us really important results. So many times we do these phase 3 trials, and then later on we say, oh, let's look at this, let's look at that, but these are actually post-op analysis that we're just doing because we have some idea. Here, actually, when we designed the trial with a statistical rigor, we were thinking we are going to measure their output at 12 weeks, at 1 year, at 1 year and a half. We're going to look at their survival, and this was all pre-planned. So here, this slide, you see the analysis of this COMMAND study, indicating basically that when you look at the response of luspatercept compared to epoetin alpha, that was the ESA that was used on this trial, you basically are doubling that. So it's like 60% versus 35%. Now, what this slide doesn't really clearly show, that I think we need to emphasize, is that in this study, we had a dual endpoint. So to be called a responder, you had to be transfusion independent for that period of 12 weeks. But in addition, you should have an increase in hemoglobin of around 1.5 grams. So this is quite important. So a responder was someone that had a significant increase in hemoglobin plus that duration of transfusion independency. This was actually the first study ever conducted with this kind of, what I think, more solid response criteria. Of course, having a response is great, but you want to look at the durability of this response. And here you see data that I had the opportunity to present at ASCO a few months ago, looking now in significant long follow-up at the duration of these responses. And if you go, for instance, in the table, I think I can show it here, I'm not sure, yeah. You will see it's 150 weeks versus 95. So basically, you're almost giving an extra year of response. And remember, response is the increase in hemoglobin plus the transfusion dependency for those patients receiving luspatercept versus those on the ESA. So this actually is quite a significant, remarkable result. And then with this long follow-up, what we see is that now a third of the patients actually are still responding if you look at those that are more than a year and a half on therapy. So quite remarkable results when you use this compound as a first-line agent. Now, we had planned a secondary endpoint to look at survival. And I remember when we were designing the trial, people say, why would you be interested in looking at survival in a study of low-risk MDS with a drug that, quote-unquote, does not have anti-leukemia activity? This is actually very interesting because people now, traditional leukemia, we want to get rid of the cells, get rid of the mutations, etc., and we associate this MRD with survival. But in MDS, this may not be the case. First, the stem cell is always affected. So it may not be able for us to actually do that. And there may be some other factors that affect the survival of our patients. So this is, again, a pre-planned analysis looking at the survival of the COMMANDS trial. So this was first presented at ASCO, later by Dr. Santini at the IHA meeting. And what you see is that now we are starting to observe a separation on the survival of these patients with kind of across here around, I think it's like around between 20 to 30 months. That is the expectation, actually, because remember, these are patients with low-risk disease that you don't think they're going to progress or die that quickly from the disease. And now these curves start to separate. So this is really fundamental signal, because this is for the first time in a phase 3 trial of an intervention like this, kind of aiming at anemia, where we're starting to see an improvement in survival. And I think the question for us is, how does this happen? Because again, there is no modulation of this mutation, so there's no anti-leukemia activity of the compound. The molecular burden of the disease is not going to change. So it's actually quite a robust, also pre-planned prospective analysis looking at RNA-seq pathways that are modulated by luspatercept in this trial. And you see prototypical pathways affected, like cytokine modulation, of course TGF-beta, but also other pathways that may affect cardiac function and other kind of systemic processes that could be involved in the improvement in survival of these patients. So I find this data really important, and we're really working hard trying to come with a good analysis that will give us some idea of why this happens. So I think this is actually fundamental. Now, Dr. Diaz-Campello, a couple of years ago, published what I think is a fundamental paper showing a little bit of the same with lenalidomide at low doses in del(5q) minus MDS. And so this suggests actually that we could intervene in first-line therapy in a specific subset of patients and start thinking about prolongation of the disease. We're not talking about cure, but really making these patients live longer. So we are very excited about this. Now, the other thing that is really interesting from this COMMANDS late analysis, and again, not really expected, because we were thinking about these drugs at the beginning just as pure modulators of transfusion burden, but we're starting to see that there is an impact on the rate of transformation from low risk to high risk disease. Now, if you look at the cause of death in patients with this disease, number one is infection, number two actually is a cardiac event. Around 20 to 30 of these patients, by our data historically, will go and eventually transform with time into high-risk MDS, and some of them maybe to acute myelogenous leukemia. So what we're starting to see here is that the rate of transformation from the low risk to high risk appears to be attenuated by the therapy. This is also fascinating. Again, we're modulating with this luspatercept some of these inflammatory pathways, and the question is, you have this mutation, those trigger some type of inflammatory cytokine. What do these drugs do to modulate that effect, and how that actually may be slowing the progression of this disease? That's actually also a very important aspect of the analysis from the COMMANDS trial. Now, this is some data that is going to be presented at the meeting, looking actually at whether this is something that you see also outside the context of the COMMANDS trial, so real-world data, and then this idea actually of, should we start using these compounds earlier in the course of the disease, before they fully become transfusion dependent. You know, to design a study like COMMANDS, you have to be transfusion dependent, so you can then measure the transfusion dependency. But the reality is that may not be the optimal way to use these compounds. And indeed, for instance, the most advanced label is in Japan, where basically our colleagues there can treat these patients with anemia without really having this factor of transfusion dependency. So this is data that will be presented by Dr. Santini, looking at this issue of patients that are ESA-naive early in the course of the disease. And what you're seeing there is that those patients may respond in close to 90% of the time. So an early intervention, similar to what Dr. Campello did with lenalidomide, may be quite effective for this group of patients. And this has been actually evaluated on a trial that is ongoing, and many of us are on that study, called the ELEMENT trial. I think, I don't know what the answer of the study is going to be, but here, basically what we're doing is in transfusion-independent patients. Now, they have to have some degree of anemia, I think hemoglobin less than 9.5 or something like this, if I recall correctly. Patients are now randomized between ESA and luspatercept, trying to see what happens if you intervene early. So I don't know who is going to win here, but I think the answer is going to be extremely important for us because it's going to really tell us in a prospective way if starting therapy in this group of patients with some degree of anemia but not transfusion dependent yet will actually change the natural history of the disease. My hypothesis will be that it will. I don't know which drug will be better. And I think that we're going to see robust transfusion responses that may last actually for a long period of time. So this may be a study that really changes our approach to the disease. So hopefully we'll get this data time soon. So with that introduction, let's see if we can answer these questions. So remember, we have this reconsider this individual with the low-risk MDS with non-del5q, 25% ring seroblast with SF3B1 mutation, anemia, transfusion dependent, EPO level 190, so kind of over 200, probably the response to ISA will drop significantly. So you still have a chance if you decide to do that to give them an ESA. So what will be your options? Continue the red cell transfusions, start an ESA, start luspatercept, start lenalidomide, or a short course of therapy with an ESA and then see what happens. We can vote. I think you have to scan the screen. Okay, so let's see if I understand this. So, okay, now it's coming. Perfect. We're voting. Actually don't know when it stops, so it stops. Okay, so let's go. So this is the pre and post. Okay, so I think it's clear. The good news is that instead of just continuing the transfusions, all of you decided to, okay, we should do something about the patient. At the beginning, around 20% of you said, okay, an ESA. Remember, this is an RS positive patient, so this is the group of patients that really will benefit from luspatercept. So drop a little bit. And I think now it's clear after listening to this data that the majority of you, okay, this is now moving fast. Okay, so I think the answer from that was most of us will consider the luspatercept for the RS positive patient. Now, the other issue is, what about this consideration of luspatercept in an earlier stage disease? So hemoglobin more than 8, transfusions 2 units, EPO level less than 100 at baseline. So this will be a group of patients that maybe we have never done anything, or maybe some of us will consider an erythropoietin stimulating agent. So let's see what you think about this. So this is the third one. Please vote. While you do that, I'll read them for you. So no evidence to use early kind of intervention. I'm not sure about any evidence. I'm sure. Yeah, I think potentially this could be important data. Okay, so some of you said there is no enough evidence. Some of you think not convinced, unsure. But it seems that most of you will start thinking about an early intervention for these patients. Of course, we'll wait for the results of the ELEMENTS trial, but I think that's where the field is going to go. I think eventually we'll be in a situation to really start early intervention. And again, that's very much based on the CintraRep trial that Maria ran. And with that, I think we move to the next, please. Okay, so basically, the next question on this individual is, what are the response benchmarks? I mean, what is this that you will be doing to assess the response? Now, we talked that in the COMMANDS trial, there was an increase in hemoglobin and this transfusion independency. So that still, I think, is really fundamental. The other issues are we asking for more? The quality of life, the improvement in survival. So that is something that I think is going to be part of the discussion more and more when we offer these compounds. Just a couple of practical issues in terms of how these drugs are dosed. This is actually quite important. And I don't know in Europe or in other countries, but in the United States, we still have to educate our colleagues a little bit. You start with this dose of 1, then you go to 1.33 after a couple of doses or when needed, and eventually you can go up to a dose of 1.75. Now, there is also an interesting concept that is the higher the hemoglobin, the better your patient is going to do in terms of overall survival. And this is actually data that will be presented by Dr. Su also at this meeting. So those individuals that get responses with over 10 grams of hemoglobin, they do significantly better than the others. And lately I've been telling this kind of anecdote, pseudo joke, but it's actually a true story, where a patient of mine who's on the ELEMENTS trial is asking me, doctor, what is your hemoglobin? And I said, okay, I don't want to share with you. I said, no, I really want to know. So I tell him, well, it's kind of, I do a CBC once a year. Actually, it was 15 grams the other day. And then he is like, why you kept me at 11.5? In other words, why are we staying at these hemoglobin levels where I'm still anemic? So this is actually quite important and is now being evaluated in a number of clinical trials. So this, again, will be presented at this meeting, was first introduced by Mateo de la Porta Atija, and it's this Maxilo study, that the idea here is to start with the luspatercept at the full dose. And that is associated with an increased rate of response. My issue with this actually is the threshold. Like I would like the authorities to allow us to go over 12, maybe over 12 and a half. So we'll see what happens with this data. And with that, I think we're going to move it to Dr. Diaz-Campello from Salamanca, who is going to be talking about sequences in this disease.
Thank you. Good morning. Thank you. Good morning, everyone. Let's move to the next topic, trying to address the best sequence for the treatment of this patient. Here you can see another patient recently diagnosed and diagnosed with severe anemia. Generally, we try to treat early, as Guillermo commented, at least in Europe, we try to treat the patient before transfusion dependency, but sometimes the patient is diagnosed with transfusions and we don't have enough time to treat early. This patient is 72 years old, low-risk MDS with this phenotype, no ring sideroblasts, SF3B1 wild type, no excess of blasts, and normal karyotype. This is the typical patients with low-risk MDS with severe anemia at diagnosis that require transfusions from the beginning to red blood cell units every month for 5 months. In Italy, the treatment should be started, at least in Europe, with hypo-alpha, because even that we have approval for luspatercept, not all the countries are allowed to use it in ring sideroblast negative patients, and the patient receive erythropoietic stimulating agents, and at the higher doses for 10 weeks. After that, the patient did not have an improvement in hemoglobin, no rise of hemoglobin levels, and no reduction in the transfusion needs, so the patient is still stable after 10 weeks of treatment. The discussion about this case is probably that the definition of this patient, is this a patient ESA refractory, or we should treat more time with the drug? What are the next steps regarding treatment, and what factor can allow us to identify the best treatment between availables for a second line in this patient regarding luspatercept and Imetelstat? Oops, sorry. Also, we can discuss about the endogenous EPO levels, because as you can see here, the endogenous EPO level at this time is pretty high, more than 500, and we know that the results of different treatments with these levels are going to decrease and be shorter. Nevertheless, we have to choose an option. Probably this patient should be better used with luspatercept, as Guillermo previously commented, but this patient was not allowed to be included in COMAS trial due to the high endogenous EPO level, and probably Imetelstat could be an option in first-line treatment due to the fact that it's not eligible for this elevated endogenous EPO level to receive ESA. And alternatively, see if the patient has received luspatercept for any way, it should be able to receive after that Imetelstat. Let's review this discussion with you. Here you can see the first question, the definition, the clinical definition for a patient that is not responding to ESA. The first thing that we have to take into account is that the patient should receive the optimal dose of ESA, higher doses of EPO alpha or darbepoetin alpha for at least 8 to 12 weeks, and we should confirm that the patient did not have a depletion in iron stores, B12 or folic acid. And if the patient is treated with this condition for at least 8 to 12 weeks and did not increase hemoglobin level or don't presented a reduction in the transfusion requirements, is of course a patient not responding to ESA, so we should discontinue for the treatment. Interestingly, in this patient, we have also a predictive factor for no response. We know that when the patient is in transfusion dependency, response to ESA is decreased, but even better, these responses are completely avoid, probably with this other predictive factor that is endogenous EPO level. When the patient is with a greater endogenous EPO, more than 500, the probability of failure is pretty high, near 100%, so probably this is not the best candidate for ESA, and as it expected, the patient failure to the treatment. Here you can see the current NCCN guidelines with options for second-line treatment in patients with ring sideroblast negative. Here you can see that it's also divided according to endogenous EPO level, and as Guillermo previously commented, immunosuppressive therapy is very uncommon in this subset of patients. I've never used in my clinical practice for a long time because the majority of these patients are not candidates for this treatment, so it's not an option probably in the majority of the patients, but we have these available drugs in this context, Imetelstat, according to the IMERGE trial, and luspatercept. Luspatercept also is the second-line treatment for patients with ring sideroblast or SF3B1 mutated disease due to the MEDALIST clinical trial, and Imetelstat is also an option in this setting. So we have to choose between one and other option. Nowadays, you have that MEDALIST trial was focused in patients with ring sideroblast or SF3B1 mutated patients after ESA failure, and we know that the overall results are near 40% of the patients with transfusion independency. Nevertheless, we can analyze, when we analyze the overall treatment period, we identify that some patients that continue treatment after the first 24 weeks with initial non-response to the luspatercept treatment, the patients continued because they presented a benefit, and they are able to reach even a transfusion independency benefit and also a reduction in transfusion burden. So the idea is that if the patient is not reaching a transfusion independency, we probably should keep on treatment because the patient could be could achieve a later response that benefit for the patient. So if we analyze the entire period of the treatment, we confirm that the achievement of transfusion independency is around 50% in the overall population, and interestingly, for patients not reaching transfusion independency, there is a great amount of reduction in the transfusion burden, as you can see here, and more than near 50% of them are going to reduce more than 50% of the transfusion requirements. So it's important that if the patient is not reaching transfusion independency in the first 6 months, we can tolerate well the drug that is expected because of no adverse event is associated with this drug and no severe adverse event, we can continue in order to try to obtain a later response or even a reduction in the transfusion burden. And here you can see, when we analyze all this data, that the median duration of this transfusion independency is very prolonged, near 2 years, as compared to only 20 weeks in patients receiving placebo. So the patients will remain stable and in transfusion-free for a prolonged period of time. This is for patients with green sideroblasts and with a very good safety profile. Interestingly, we are currently participating in the Maxillus trial, as Guillermo previously commented. We initiate the dose of luspatercept at the highest dose, that means 1.75 milligrams per kilo, and the results in the second-line setting that is presented here, and it's going to be updated on next Monday during this meeting by Dr. Zeidan, are amazing because they are increasing the rate of responses. The comparison for this trial is the results of the Medalist trial, and you can see here that up to 65% of the patients are going to respond to the drug initially, and you have to take into account that here the primary endpoint includes also a hemoglobin rise of more than 1 gram per deciliter, so it's much more strict than the Medalist clinical trial. Interestingly, the responses are sustainable over time, and you can see here near 50% of the patients reach transfusion independency for more than 2 weeks. And this trial also includes patients with no green sideroblasts that are not allowed in the Medalist clinical trial. And in this population, we achieve, with this higher dose from the beginning, 30% of the responses, 33%. So this is, I think, very interesting, because with this very good safety profile could be also an option for green sideroblast negative patients. The other available drug in this context is Imetelstat. As all you know, it's a different mechanism of action drug for these patients, and this drug is targeting malignant clones due to the fact that they have an upregulated telomerase activity. The idea with this drug is that induce apoptosis in these malignant cells and is able to potential recovery for normal hematopoiesis. This drug has been approved by FDA and also by European agency for patients after ESA failure with and without green sideroblasts, and is available only for American patients because in Europe it's still pending for commercialization. Here you can see the main results of the IMerge clinical trial, including patients with and without green sideroblasts, and including patients with a very high transfusion burden. And you can see here that 40% of them reach this goal of transfusion independency that remains stable over time. The median duration of the transfusion independency for this primary endpoint was around 1 year. And we identify that if the patient is still in transfusion independency after 6 months or even after 1 year, the median duration of this transfusion independency is very prolonged. And here you can see that patients that are still in transfusion independency after 1 year have a expected median duration of transfusion independency of near 2.5 years. So this is amazing for the patient. we can identify the benefit of this treatment in different populations, and you can see here the role of this drug in treatment-naive patients due to to ESA, due to the fact that these patients could have increased levels of endogenous EPO. And in this setting, in patients not eligible to ESA, we have only 43 patients, but the results are promising because more than 50% of them are going to reach the transfusion independency. Regarding the patients after ESA, we can see that all these patients respond, and the responses decrease according to the endogenous EPO levels, traducing that probably when we treat the patient early, as we have commonly previously, the results are going to be even better. And these results decrease according to the increase in the endogenous EPO level for all the times for the transfusion independency. And regarding the type of failure of ESA, you can see here that the most responders to Imetelstat after ESA failure are those that initially responded to ESA. Also, refractory patients response a little bit poor, and ESA ineligible, as we can comment on it. And interestingly, in this trial, we have an extension phase in which some patients with luspatercept treatment before Imetelstat can be included. And here you can see that the results are pretty similar to those previous, and up to 1/3 of the patients can respond to Imetelstat after luspa failure. So probably this drug should be put before Imetelstat due to the fact of the hematological toxicity that this compound had. Here you can see the long-term follow-up update for the clinical trial that is going to be presented by Dr. Santini in a poster presentation tomorrow afternoon. And as you can see here, a trend towards better outcomes are expected with the patient receiving Imetelstat. This study was not powered to identify these differences. It's not statistically significant. There are only a few months of benefit, but it seems to, like Guillermo presented in the luspatercept trial, probably decrease in the progression to higher entities. The overall results in this trial was associated with the achievement of transfusion independency and hemoglobin rise, probably according to the response to treatment. And we are thinking about that the patient is responding probably has better outcomes due to the fact that we are free of transfusions and all these complications. With all this information in mind, you have to choose for our patients. Remember that it's a ring sideroblast negative patient with transfusion dependency, a high endogenous EPO level after ESA failure. What do you think, which drug do you select for the patient? Lenalidomide, luspatercept, Imetelstat, decitabine, serasudidine, or you don't know? You can choose the question. The answer? Well, you can see here that the majority of you move to Imetelstat. It's an approved drug in this context for ring sideroblast negative, and also some doctors could initiate luspatercept due to these pretty initial results of the Maxilus trial. In our patients, according to the label, we decided to start with Imetelstat, and we need to know what happened with this drug in this context. Because as I can previously comment, is a completely different drug in this setting, and toxicity is also completely different from luspatercept. We expected that the majority of the patients are going to develop adverse events related to hematological complications, and as you can see here, grade 3 and 4 for thrombocytopenia and neutropenia are present in the majority of the patients. Nevertheless, two messages for your information. The first message is that these cytopenias generally are of shorter duration. You can see here 1.5 to 2 weeks for resolution, and the majority of them are going to be resolved before the next cycle. So in the majority of the cases, the patient, when comes for the next cycle, is recovery for these cytopenias. And another important message, the second one, is that these cytopenias are not translated in clinical consequences for the patient. That means that the patient did not have an increase in bleeding, infections, or other complications due to these cytopenias. They are only numerical issues and not clinical issues for the patients. Importantly, we have to start with the current dose, that is 7.5 milligrams per kilo, intravenously over 2 hours every 4 weeks, and we need to premedicate the patient with these two compounds in order to avoid side reactions. Here you can see that if the patient develops grade 3 and 4 adverse events, we need to delay the dose if the patient don't have a recovery for the next cycle, and of course start with dose reduction with these two types of reduction. First reduction at 5.6 and the second one 4.4. Importantly, you need to administer at least 6 doses in order to try to wait for response. Only you have to discontinue if the patient presented unacceptable toxicity, or if the patient after these 6 doses did not have a decrease in the transfusion burden. But don't discontinue if the patient presented adverse events related to cytopenias, because as you can see here, and we are going to see in the oral presentation next Sunday by Dr. Seidan, the presence of cytopenias in terms of platelet reduction and neutrophil reduction is associated, when it's present during the first 2 cycles, to response of the patient, like it happens with lenalidomide in the LEL5Q setting, probably due to the fact that probably the bone marrow is being removing for clonal cells and started to repopulate with normal cells. You can see here that those patients with the greater reduction in platelets and neutrophils count are those that are going to be responding according to different variables: hemoglobin rise, transfusion independency, and hematological improvement. So if the patient is developing this cytopenia, we have to try to keep the patient on treatment with safety recommendations according to dose delay and dose decrease. And this is my last question regarding this patient. We started Imetelstat, and he presented an initial episode of grade 3/4 hematological toxicity. What do you do with the standard dose of Imetelstat? You have these 5 choices.